maternity program. Today, we will be talking about delivering healthcare professionals a new world of billing in the ACHN program. You will not hear any sound until the webinar begins. Well, it has begun. Use your chat box function to type in the questions, and also questions will be answered at the end of the webinar. So we're going to be talking about the ACHN operation, the operation of the Alabama Coordinated Health Network program. Each network will provide care coordination based on the recipient's county of residence and will be expected to develop a care coordination delivery system that is unique to their region. Networks will be required to notify recipients that they are required to participate in the ACHN program for Medicaid to pay for their pregnancy and delivery services. This is the same function required by primary contractors today. Networks will also be responsible for creating their own network of delivering healthcare professionals. This means that the networks must have a collaborative relationship with delivering healthcare professionals. To have an effective selection and choice process for coordinating maternity care, the network will have the responsibility of establishing a comprehensive network of delivering healthcare professionals within 50 miles of all areas in their region that can provide prenatal delivery and postpartum care in a coordinated care delivery system. Hopefully, you have already signed an agreement with the network in your region, and if you've not done this, I urge you to go ahead and do this. These are eligible maternity recipients, SOBRA or full Medicaid, and any in these categories will qualify for maternity services. Next, we'll talk about the care coordination program. And although I'm going to cover just the requirements of the maternity program, the ACHN will have just as many requirements for the general Medicaid population and family planning recipients. Recipients may need help in making and keeping appointments, so care coordinators will be there to assist them with this. Care coordinators may help coordinate and facilitate referrals for your patients. Care coordinators will track recipients throughout the pregnancy and postpartum period. Care coordinators will transition recipients to non-maternal care coordination after the postpartum period if needed. For example, a high-risk recipient that has diabetes may need to continue care coordination services through the general Medicaid population. Care coordination may also be provided in any setting the recipient chooses, such as a library, home, physician office, or hospital. Continuing on with the care coordination program, care coordination services provided by the ACHN for the maternity include, and I've listed them here, but I'm going to go over a little details for each one of these. The first one is face-to-face eligibility assistance. To assist eligible individuals with establishing Medicaid eligibility in the first trimester, this is what the care coordinators will be assisting. They're specifically trained to assist the recipient in obtaining that eligibility. And this encounter must be completed by a certified application assister. Nurses and social workers in the program will be qualified to do this. The second second visit is a first face-to-face encounter. That first encounter for all pregnant women eligibles, and this encounter includes, but is not limited to, the completion of the psychosocial assessment and the initial care plan. The next visit is a follow-up face-to-face encounter. This encounter may be done in the second and the third trimesters if needed. If the recipient is identified as a high-risk recipient, then the visit can be made in the second and third trimesters. The next visit is an in-face delivery encounter. And this visit is done in the hospital. If the visit is missed in the hospital, then the visit can be done within 20 days in the home of the recipient. And that's if it's missed in the hospital. The next visit is an in-home face-to-face postpartum encounter. These visits will be done for our high-risk recipients, and this encounter will occur in the home, and it will occur between 4 and 8 weeks of the delivery date. Care coordination transition. To ensure a smooth transition from the current maternity program to the ACHN, Medicaid is ensuring the following. The ACHN will obtain historical data from the primary contractor, and this historical data includes the psychosocial assessment and the care plan. So the psychosocial assessment and the care plan will be shared with the new ACHN provider so that there will be a smooth transition from the maternity contractor to the ACHN. Beginning October 1st, the ACHN will begin accepting phone calls from the recipients to schedule care coordination visits for November. The care coordination visits will actually start in November. Next, I will be going over the delivering healthcare selection referral. All maternity claims must have a delivering healthcare professional selection referral number from the ACHN to receive payment from Medicaid. This number is the NPI of the network entity. Even though you will have this number from regularly working with the network, the ACHN and the delivering healthcare professional are responsible to ensure collaboration, and the network will ensure this to Medicaid by sending a list monthly of DHC participating delivering healthcare professionals. This will ensure that proper payment is made to delivering healthcare professionals for the maternity services provided. This is a snapshot of the delivering healthcare referral form. The website, and it's in the procurement section, and it will be used by the ACHNs to provide the referrals to the delivering healthcare professionals and to the recipients. No delivering healthcare professional referrals will be required in October. During the month of October, delivering healthcare professionals can bill their claims to Medicaid if the delivery occurred in October, and Medicaid will pay that claim without needing an ACHN referral number on the claim. For deliveries that occur November, the delivering healthcare professionals should contact the ACHN for a verbal referral and the ACHN will follow up within 24 hours with a written one. Please be aware that these referrals need to be in your record beginning November 1st in case you are audited. We do need to see that you've had that collaboration with the ACHN. Beginning October 1st, the delivering healthcare professional will be able to provide a referral to a specialist. Previously, delivering healthcare professionals had to go through the PCP to receive a referral for non-maternity services. Today, beginning 10/1, you will no longer have to have a referral from the PCP to provide services outside of maternity care. And also, the delivering healthcare professional will be able to provide a referral to a specialist instead of going back to the PCP for this. I've also included in here a link to a referral form, to our Form 362, and the link will bring you right to the referral form. Quality improvement. The areas of focus for quality improvement for our quality improvement program are reduction of infant mortality, substance use disorders, and prevention of childhood obesity. Delivering healthcare professionals can positively impact quality by performing a prenatal visit in the first trimester, performing a postpartum visit within 21 to 56 days of the birth, and participating in quality improvement projects with the ACHN. The ACHN will be sending in quality improvement projects to the agency, and they may be reaching out to work with you on some of these projects related to infant mortality. So next we'll go into payments and rates for delivering healthcare professionals that are contracted with the ACHN. And I wanted to reiterate here that in order to receive payment for maternity services, a delivering healthcare professional must be contracted with the ACHN. If you are a delivering healthcare professional, Medicaid will reimburse a bonus payment for an initial visit in the first and a postpartum visit, in addition to your regular prenatal visits and postpartum visits. So I want to reiterate that this bonus payment is on top of your regular claims payments for your antepartum visits and your postpartum visits. Claims will be reimbursed to delivering healthcare professionals directly from Medicaid. You will not be going through the ACHN to receive payment. Delivering healthcare professionals will have the opportunity to receive, and I've just mentioned this again, but I just want to go over it again, the two bonus payments, an initial prenatal visit made in the first trimester and one postpartum visit made 21 to 56 days postpartum. To bill Medicaid for maternity services, you must participate in the ACHN program, as I've mentioned before. Only one agreement with the ACHN is necessary and will cover you for all 7 regions. Collaboration with the care coordinator will help ensure early access into care for your recipients. Active participation. Participating with the network and signing the agreement is only the beginning. Active participation means that you must assist in the development of the care plan with the ACHN as you do today with the primary contractors. Also participating in the delivering healthcare professional selection and referral process and collaborating with that ACHN and providing data to the ACHN, the same data that's provided today. Today, delivering healthcare professionals bill Medicaid directly or bill the primary contractor for services provided. Medicaid global rates are between $950 to $1,300 for urban and between $1,250 to $1,700 for rural rates. Primary contractors pay delivering healthcare professionals in different ways. Either a global rate that includes ultrasounds, or they allow the delivering healthcare professional to bill separately for services outside of the global rate. Some primary contractors pay a different rate for rural and urban. Some only pay one rate for all. The average global rates paid by the primary contractors are between $1,300 to $2,273. This slide shows the current Medicaid delivery rates and the future ACHN delivery rates that will be effective for the dates of service 10/1/19 and after for the rural and the urban delivery procedure codes. And you see here listed all of the delivery codes. Procedure codes 59400 and 59510 are global delivery codes for vaginal and cesarean deliveries that include the antepartum delivery and the postpartum care. These rates are increasing by $90 to allow a rate of $1,790 for rural and $1,390 for urban. Procedure codes 59409 and 59514 are vaginal and cesarean delivery only codes. These rates are increasing by $90 to allow a rate of $1,340 for rural and $1,040 for urban. Procedure codes 59410 and 59515 are vaginal and cesarean delivery codes that include postpartum care. And this is when antepartum care was not provided. These rates have also increased by $90 to allow a rate of $1,390 for rural and $1,090 for urban. Procedure code 59610 is a global vaginal delivery, including the antepartum delivery and postpartum care after a previous C-section delivery. These rates have also been increased by $90 to allow a rate of $1,790 for rural and $1,390 for urban. I wanted to bring to your attention here on this slide our urban and rural rates. Rural rates apply to the county location of the delivering healthcare professionals' offices. A map showing the urban and rural counties for providers may be accessed on the following link. So I do have a link in this presentation that will bring you directly to the map that shows the counties. And I also wanted to let you know the rural rates are paid based on the counties, and based on the address of the delivering healthcare professional that is in Medicaid's current system. This is a list of procedure codes and rates that include cerclage and ultrasounds that delivering healthcare professionals may bill separately to Medicaid outside of the global delivery codes beginning October 1st. Cerclage, 2 ultrasounds, and other procedures are included in the global fees today paid by many of the maternity contractors. But when we start 10-1 on 10-1, these procedure codes can be billed separately from the global. This slide is also a continuation of the many ultrasounds that may be billed to Medicaid fee-for-service outside of the delivery code. Beginning October 1st, prior authorizations will no longer be needed for maternity ultrasounds. And although a prior authorization is no longer required, maternity ultrasounds must be medically necessary, and the agency will be monitoring these to ensure that medical necessity is met or has been met. Laboratory services. A hematocrit and urinalysis is included in the global delivery fee as part of antepartum care and may not be billed separately to Medicaid. All other lab services can be billed separately from the global if Medicaid policy allows it. Bonus payments to delivering healthcare professionals include the initial prenatal visit made during the first trimester and 1 postpartum visit between 21 and 56 days of delivery. Medicaid will reimburse the delivering healthcare professionals $100 for each visit, and these codes must be billed on a separate claim from your other codes. Remember that delivering healthcare professionals can bill antepartum codes, including prenatal visits and postpartum codes, and are reimbursed regular fee-for-service, plus your bonus payments. So you will receive these bonus payments on top of your other codes that you're also billing, on top of your regular fee-for-service payments. When a global delivery code for a vaginal or a cesarean section, which includes antepartum delivery and the postpartum care, 2 ultrasounds based on procedure code 76805, bonus payments for your initial, prenatal, and postpartum visits are all added together, the approximate total for the rural rate would be $2,292, and the total for the urban rate would be $1,892. These amounts are comparable or even better than the rates paid today by Medicaid or the primary contractors. Payment for the FQHCs and the RHCS related to maternity. The payment for FQHCs and RHCS will be based on the following policy. The reimbursement to the FQHCs and RHCS will be made via PPS rates, prospective payment service rates, and your fee-for-service rates. And I'll go into more detail about the fee-for-service rates on the next slide. PPS rates to Medicaid for each antepartum visit made using E&M codes. The E&M codes are included in the 14-visit limit for physicians. All other codes will be billed fee-for-service, and I will go into those codes that trigger a fee-for-service payment on the next slide. The table below, and this is a table that will show the FQHCs and RHCS which codes should be billed fee-for-service. The first one is 59409, vaginal delivery. 59430 for post-delivery care, that's your postpartum visit. 59514, cesarean delivery. 59612, vaginal delivery after a cesarean delivery. 59618, routine obstetric care, including antepartum care, cesarean delivery, and postpartum care, following an attempted vaginal delivery after a previous cesarean delivery. And then 59620, cesarean delivery only, following attempted vaginal delivery after a previous cesarean delivery. I wanted to also go into a little bit of detail here. If nurse practitioners or nurse midwives perform any of the antepartum care or the delivery services, they will be reimbursed 80% of the physician fee schedule. PCP payments and overrides. An override may be provided by Medicaid in the following situations. And remember, before I'm going to go into this, I'm going to let you know that during our transition, the physicians will need to send in overrides to Linda White in our maternity program for certain things that were done prior to 10/1 while the recipient was in the primary contractor program, our current maternity program. So an override may be provided by Medicaid in the following situations. When antepartum visits occurred prior to 10/1 and the delivery was done by another physician on or after 10/1/2019. For ultrasounds or for any procedure that could be billed separately and apart from the global delivery. The person that you would contact for this is Linda White, and her email address, and I will update this slide. I did update this slide. Contact Linda at linda.white@medicaid.alabama.gov for assistance with this, and she will help you get these claims paid. Required BMI reporting update. I know we talked about BMI in previous presentations, and I'm bringing it up again today because people have been asking several questions about it. But I wanted to bring to your attention that the pregnancy diagnoses are excluded from the BMI requirement. So that means while the recipient is pregnant and there is a pregnancy diagnosis on the claim, that requirement will not be necessary. We've heard feedback from several of you, and we've taken it into consideration regarding the BMI. And as a result of this feedback, we've made a slight modification to ease the requirement. BMI coding will still be required on each claim. However, the same BMI can be reused until the next well child check, where a BMI is typically determined, or sooner if the physician feels there is a clinical need for a BMI redetermination. We'll be monitoring the issue, and over the next year, we will monitor this issue. Since we are so close to ACHN Go Live, a major modification would not be reasonably feasible. For those recipients that are wheelchair bound, and it may be difficult to obtain a BMI, an override may be requested. Send the overrides to managed care for consideration. Medicaid covers immunizations for maternity recipients separate and apart from the global delivery code. Tdap and flu vaccines are covered vaccines for pregnant women, and these vaccines can be billed today separately and apart from the global delivery code. Reminder of participation requirements. To receive payment for services, delivering healthcare professional groups must actively participate with the ACHN. And this active participation is defined as, first you have to sign that agreement, then you have to participate in the development of the care plan with the ACHN and participate in the delivering healthcare professional selection and referral process and provide data to the ACHN. And it's the same data as you provide today to the maternity contractors. Training and technical assistance. DHC will provide technical assistance to providers to assist in getting ready to bill Medicaid for services. Today, providers bill Medicaid and the primary contractor. The transition to Medicaid billing should not be overly cumbersome, but DHC will be there to assist you. There is contact information on this slide if you go to this link, and they are ready and willing to assist you. They've already been out to some offices and are doing trainings. In summary, there are some primary points that we all need to remember. Maternity contractors will no longer contract with delivering healthcare professionals. Claims for maternity services will be reimbursed by Medicaid. You will have the opportunity to receive 2 quality bonus payments in addition to your fee-for-service payment. DHC is available to assist your office staff to provide billing assistance, and that immunizations are covered for pregnant women. Flu and Tdap vaccines are covered codes by Medicaid. Also want to remind you that Medicaid's website is www.medicaid.alabama.gov, and there is a link to FAQs on our website. There's also a link to submit any questions to ACHN at medicaid.alabama.gov. Now we'll go into our questions.
Great. We'll try to go through as many of these questions as we can in the time that we've got allotted. I do want to say that later we can provide written, formal, official answers to these questions since we've not had time to prepare the answers for the questions that are submitted. But we will give the best effort at answering the ones we've got at this point. So we'll just start back from the top and try to work our way down. Some of the questions that are asked have been answered in the presentation, later in the presentation, relative to when the question was asked. I'll ask Jerry to help supplement me in terms of the answers. So if she comes in behind me and provides further detail or correction, then what Jerry says will be what we'll go with. First question is a separate ACHN referring number required when a patient is referred for high-risk services? And the example is given in Mobile. If so, what is the process? The answer is yes. The purpose of the ACHN referring number is to make sure there is communication and conversation about the patient with the actual network, to make sure the network is aware of the recipient and to begin the care coordination process if it is not already started. Well, obviously, it'll be important that they also be aware of a referral to a tertiary center like this. So yes, a referral number will be important. Obviously, you know what the number is once you know their MPI number, but the ACHN will be monitoring these kinds of conversations and will confirm that new contact was made in order for future billings to be paid, because it is so important to establish the communication between the network and the patient and the provider. All right, let's see, is it possible to get, someone just slid the question away from me, so hang on just a minute, okay? Okay, is it possible to get the slides prior to the meeting? Well, obviously, we've just now shown the slides and the meeting has occurred. We will be posting the slides in a recording of the webinar later today or tomorrow. We have posted already all of the other webinars, and you'll see the slides associated with those. So, and the question was answered that the slides would be answered or would be posted after the webinar to our site. When billing the postpartum visit that includes family planning services, will we continue to bill, and they list a specific code, 99212-FP. So when billing a postpartum visit that includes family planning services, will we continue to bill this family planning code? The answer I'm receiving from my staff is yes, because it is, you know, presuming you meet the requirements for that code as a separate and identifiable service, then the answer is yes. Okay. Are we to bill QOL, which I presume is quality of life, for visits prior to October 1, 2019? What happens if a patient already enrolled in quality of life and does not get enrolled in the ACHN? Do we get paid? We cannot quit seeing patients if they're already seeing our physicians, and we don't expect you to have to do that. So for visits prior to October 1, if a delivery has not occurred prior to October 1, Jerry did cover later in the presentation that the fee-for-service billing for those visits would go directly to the agency. And she also gave you the particular person's name even to contact about that. So yes, you would get paid for those visits if the delivery had not occurred prior to October 1, and there are standard ways for billing those, and they were covered in the presentation. So, would you get paid? The next question was, what happens if a patient already enrolled in quality of life and does not get enrolled in the ACHN? Do we get paid? You would get paid for the visits prior to October 1. On October 1, you need to have make sure you're having contact with the ACHN, but as Jerry also covered in her presentation, a referral will not be required for claims to be paid during the month of October. Now, in the month starting November 1st, you absolutely will have to have a referral number in order to get paid. All right? Next question is, how will the transition happen for providers of maternity waiver districts 10 and 12, since we've not had care coordination since 2016? Fortunately, in this situation, it is fortunate in that you already have a lot of experience with fee-for-service billing, and obviously that's what we're all going to now is fee-for-service billing. The difference will be, for you particularly, will be starting November 1, because you will have to have the referral number in order to have your claims paid. So the transition for you will probably be smoother in that regard, in that you're more accustomed to doing fee-for-service billing. But we encourage you to have an active dialogue with your ACHN. You understand their processes for doing things such as collecting data, et cetera, and how you will have the communication around care coordination once care coordination physically starts on November 1. The next question is, we currently do not see patients until they see a care coordinator. Do we not see patients in October that are new? You definitely want to see patients in October that are new. That is very important. As Jerry covered later in the presentation, a referral number from the ACHN will not be required during the month for dates of service in October, but you will require a referral number for dates of service starting November 1 going forward. So don't stop seeing your patients, and if you have new ones that come in, that's fine. You will be reimbursed for those services, assuming you meet all the other regular requirements for fee-for-service payment. Next is, how do we get an ACHN referral starting October 1st? Do we have to bring all 500 of our current pregnant patients in to call and schedule an appointment with the ACHN? Will we receive an ACHN referral number for billing purposes? I think we've basically already answered that question. We have asked the ACHN for their NPI and Medicaid ID, and they said they do not know. Can we get that info? This is for Gulf Coast Total Care. I can assure you that Gulf Coast does have an NPI, and they should have a Medicaid ID. So I would reach out. The contact list for Gulf Coast and for all of the ACHNs is listed on our website, and you'll have not only a phone number, but you also have an email of the people who contact there, and they should be able to provide that to you. So I would encourage you to reach out to them again in light of this webinar about how to go about getting that number. And certainly if you have any problems, let us know here at Medicaid, and we'll help resolve that for you. Does a referral need to be on every claim for pregnant patients or only the delivery itself?
On every claim.
As Jerry said, it would be necessary, it will be required on every claim. Are we able to bill for the initial prenatal visits done for patients that are due after 10/1/19, or do we have to only bill the visits after 10/1/19 for the bonus payments? Let me try to answer this question in a little bit more depth, just because I think a very similar question more than once, I think even has been asked in the subsequent list of questions. This program starts October 1, so bonus payments are for qualifying services with dates of service October 1 going forward. So if you did a first trimester visit prior to October 1 for a date of service prior to October 1, there would not be a bonus associated with that. However, if your initial visit is in the first trimester and occurs on a date of service October 1 or forward, then you would be eligible for the bonus payment. Obviously, make sure you submit billings accordingly to that in order for it to be paid. There is a related question about the postpartum visit. If a female delivered prior to October 1 but came in for a postpartum visit with a date of service October 1 and forward, would you be eligible for a bonus payment? The answer is yes. Again, it relies on the date of service. If your postpartum visit falls within that 21 to 56 days, as Jerry covered earlier, and it is October 1 or afterwards that it occurs, then you would be eligible for that postpartum visit bonus payment. Next question is, as for the practices that have multiple clinic sites, will the delivery be paid at the rate based on the clinic location where they're receiving their prenatal care, or based on where the delivering facility is located? Is it possible that the ACHN/Medicaid itself possibly revisit this based on where the patient lives versus where the DHCP is located? We are surrounded by rural counties, but we are located in an urban county. We care for primarily rural patients. The rural versus urban rate is based on the address of the provider. It's not the address of the recipient, it's not the address of the hospital, it's the address of the provider. So the place of service is important, and if the place of service is in an urban county, then you get an urban rate. If the place of service is in a rural county, then you would be a rural rate. So it is dependent upon the address of the provider. So the next, So we will have to still provide each lab and sonars a data encounter sheet. I presume you're referring to data requirements from the current maternity contractor, and the request is, will you still be providing information? Jerry said in the presentation that you would be submitting the same information to the ACHNs. Now, there may be some slight differences from maternity contractor to maternity contractor. There may be some slight differences from ACHN to ACHN, but it should be approximately the same information, and the burden level should not be increased by the ACHN program. It might be decreased some, but they will still be collecting some information from you. When will we be reimbursed the bonus payment? On a check write, monthly, quarterly, or what else?
Check write.
As Jerry just said, it'll be on the check write. So when you are receiving a check write for the applicable dates of service, the bonus payment, again, assuming it meets all of the other claim filing requirements, would be paid based on the check write basis. Do we, as the doctor office, have to fill out the maternity ACHN forms, or do the ACHN care coordinators fill those forms out? Sorry, I'm not sure exactly what's meant by the maternity ACHN forms. Perhaps if you could email us and let us know a little bit more specifically about that, we'll be glad to answer the question. I'm just not sure exactly what's being referred to. The next question says the current rate, fee-for-service rate, global vaginal/C-section is $1,760. I believe we said $1,700 in the presentation. I think that's what you're referring to. So will the increase be $90 or $30? That is not our understanding. Our understanding is that the fee-for-service rate is $1,700, and then it will go to $1,790. We'll be glad to go back and research that. If you'll email us something specific about that, we'll be glad to look at your specific information relative to that. Yeah. So with being in Calhoun County, we will actually get paid less than what we are now since we are considered urban. That will depend on particulars. Jerry gave a lot of detailed information around the fee-for-service billing. We think the fee-for-service billing results in a payment that is comparable to what you receive from the maternity care program today. Again, I encourage you to look at the whole scope. Don't just compare a single line item to your current total global fee. Your current total global fee, remember, includes lots of things. Not only does it include 2 ultrasounds, but it includes a whole host of other procedures that may or may not actually be performed on a given individual. But things like cerclages and other procedures that are considered to be covered in the current maternity global fee are not part of any global fee in the future program starting on October 1. So you will be able to, as Jerry pointed out, bill a number of things separately from the global fee, which could easily result in your payment being even higher. Certainly, as described, when you bill the ultrasounds that are described, and when you bill, assuming you are able to achieve the bonus for the first trimester visit and for the postpartum visit, then that would, all of those factors would affect how much you get paid relative to what you get paid now. But I would encourage you to look at the total package, and I would tell you in aggregate, I think you have the opportunity to earn at least as much, if not better, when you look at the averages all across the state. Are we able to bill for postpartum visits done in October? The patients will have delivered prior to the ACHN taking over. I think I've basically answered that before. Even if the person delivers prior to October 1, but their date of service for their postpartum visit is October 1 or later, then you would be eligible, assuming the other requirements are met, you would be eligible for the postpartum bonus. So we cannot bill out for office visit 59425 or 426. Jerry covered that in the presentation, so I would encourage you to go back and look at that. She had a specific slide that actually mentioned those specific codes. I noticed it after I saw the question, so that should be covered. The next one I have says, confused. We will only receive $1,300 for delivery after October 1. What about our ladies' office visits prior to October? We won't get bonus payment for first visit because it is with quality of life in sonars. I think we've already defined what happens for dates of service prior to October 1 and then what happens for dates of service going forward. Jerry did describe, though, also that if you have a woman that you have been following with a maternity contractor, but she does not deliver until October 1 or later, you will be able to bill for the services that you have provided directly to Medicaid, and Medicaid will reimburse you for those services. So there should not be a situation like that where you provided an office visit service that you don't have the opportunity to submit a claim for. BMI coding is required on all prenatal visits. Jerry covered this in the presentation. She said that if you have a pregnancy diagnosis, then a BMI code is not going to be required. We have to have a BMI diagnosis on a shot-only visit. Let us take that one down and then give you a written response back to that one.
No, you don't. It's based on the E&M code.
Okay, Jerry said no, because if you were to submit an E&M code with it, then the answer would be yes, presuming you do not also have a pregnancy diagnosis.
Right.
Okay, currently, we do not send out a claim for zero prenatal charge, so do we send all prenatal claims with a zero charge out? I'm sure I understand this question. Let us take that down, and then we'll be glad to respond back in writing about that.
Okay. Yeah.
What about ROGAM shots? ROGAMs would be a fee-for-service billing. Will the reimbursement rate be affected if services provided are split between an MD and a midwife? The services are paid based on who provides the service, as we described earlier, and Jerry's already discussed that.
Right.
What immunizations will be covered went too fast. Basically, what Jerry was trying to cover earlier was that immunizations, even today, can be billed fee-for-service outside of the global. She gave the specific example of a flu shot and a Tdap just because those are the ones we've received a request about to clarify. But immunizations, qualified immunizations, can be paid outside the global fee-for-service billing. Will the age be lowered for a pregnant patient to receive an immunization at her OB office so we can receive payment? I'm not sure about the age being lowered.
Yeah.
This can be paid in women of any age at this point. If you have other questions or you've received some sort of denial about that, please email us and let us know that. Are the charges for newborn deliveries affected? I'm not sure about the question. I think we've basically answered about deliveries, so I'm going to move on. When will we find out how to do encounter data? That will be a very important discussion for you to work with your ACHN about specifically what information they want. Now, encounter data is a term that means different things to different people. So I would encourage you to speak with your ACHN about what data they're going to require and collect. And remember, physicians occupy 1/2 of the board seats on every ACHN, and we'll have an opportunity to impact ACHN policy around this issue and other issues. So I would encourage you to dialogue with the ACHN, with the medical director, and with other board members around information that the ACHN has to collect. When will we receive the first attribution file? When will we receive the first attribution file? I think we can anticipate that
beginning of October.
The beginning of October. So I think it will be, in the near future that you will receive that attribution file. Will the eligibility file include the attributed PCP and aid category? We know this information is on the portal. However, we need to determine if our eligibility file will include this information. Let me read that again. Will the eligibility file include the attributed PCP and aid category?
The attribution.
Yes, through the web portal or the PES, DES system, Provider Electronic Solution software. It should be eligible. We do have a person from DXC here who's supplied that information. So can you clarify that referral for services outside of maternity. Gary covered earlier that maternity physicians do not require a PCP referral.
And that's for services other than maternity.
Okay. When answering the first question about referral for high-risk services, you didn't say what the process is. Will we just notify the care coordinator or notify the ACHN directly?
The ACHN directly so that they can get you another delivering healthcare professional referral.
What will the file format be for the attribution file, PDF or Excel? I'm not sure we know that at this moment. We think it will be PDF. Sorry, I don't have an exact answer right now. Will the facilities, parentheses, hospital, require a referral for maternity service?
No, they don't today.
When will we find out our care coordinator's name? That's a great question. Let me encourage you to reach out to your ACHN and have a discussion. Obviously, it'll be a determination by the ACHN about who exact care coordinators will work with which practices and whatnot, and determination of location at the practice and that sort of thing is an ACHN level decision working with providers. So I would really encourage you to work with the ACHN. And I'm sure that the answer will be relative somewhat to what size practice you have and that sort of thing, what kind of dialogue they've had with you. So I would encourage you to reach out to them for that discussion. Currently, if we have a patient who is referred to our hospital for surgery, a referral is required from the patient's PCP. Will a referral no longer be required now?
If it's required today, it will most likely be required in the future. So if you have to have a referral for a certain type of surgery today, you will have to in the future.
Since CRNPs have their own NPI, do they require a referral from the patient's PCP to be seen for gynecology services? The answer to that would be no. If the CRNP is affiliated with a physician or practice that is participating with the program, then it would be no. Which box does the referral number go in on the claim? Sorry, we've got someone looking into that right now. Let me go ahead and try to answer another question and we'll come back to that one. Would you please clarify the need for the PCP to be on hospital claims, both inpatient and outpatient? Do we need the PCP to be on the hospital claims, both inpatient and outpatient?
No.
No, that would not be required.
It depends on if they're the attending physician or not. I mean, if they were, then they would have to be.
Currently, we get $1,530 per delivery from the Step Ahead program. So what you are telling us is it will be a cut in reimbursement for us, question mark. Again, I referenced what I described earlier. Remember to look at the payment that you receive today. It includes a global payment that includes a lot of different services that could potentially happen, recognizing that every client does not receive all of those services. In the new world, the payments are fee-for-service. So you have to look at the applicable fee-for-service payments in aggregate and look at, what things you typically provide for the recipients that you treat. Did you get a bonus payment? All of those things are to be factored in for you to be able to compare reimbursement. We designed the program that actually, for most providers out there, they actually will receive as good or perhaps slightly better payment in the new program. If we bill the postpartum bonus code and the 99212FP for planning services done during the postpartum visit, is the claim going to deny for two services on the same date of service? And Jerry says no.
They must be billed, the bonus payment must be billed on a separate claim though, or it will deny.
We're going to go back now to the question about where to place the information on the claim form.
If it's a CMS 1500 claim form, that information should be provided in field 17A and 17B. If you're billing on a UB04 claim form, that information would be provided in field 78.
Thank you, Tori. We bumped up against our time and actually a little bit. So let me make sure to remind everyone about the link to the provider, the special edition provider insider. We sent it out. Many of you may have already gotten it in the mail, but certainly it's also on our website. We do also encourage you to go to the Medicaid website and go under the provider section. You can go to the ACHN tab and then go to the provider tab, and it will give you lots of information. You can also look under news and notifications tab for that. We recognize there are many other questions here. I think we did get to the majority of the questions, though. We do have a few. We'll look through there and see if there are some questions we don't feel like we've already answered, and we'll be pushing out answers relative to that. But thank you so much for your attention today and participating in the webinar. We really appreciate it. This will be recorded and placed on the website soon. Thank you very much.